My name's Emma Robinson. I'm a Neuromuscular Research Physiotherapist and I work for the Walton Muscular Dystrophy Research Centre in Newcastle upon Tyne in the UK. Limb-girdle muscular dystrophies are a group of neuromuscular conditions. There are currently around 33 that have been developed, but they're very rare. Dysferlinopathy is one of the limb-girdle muscular dystrophies, which is caused by a sort of reduction or elimination of the protein dysferlin in people's genes. In terms of when it was found, the way that limb-girdles are named, they have a certain order of the way that they're named, which is in terms of when they were discovered and whether it's a dominant or a recessive genetic condition. So Dysferlinopathy is 2B, so it was one of the second limb-girdles to actually be discovered through genetic sort of Western blot. They do a process called a Western blot, which signifies which protein is missing, and that's how they that's the sort of diagnostic tool, if you like, for dysferlinopathy. With limb-girdle muscular dystrophies, the pattern of muscle weakness affects the pelvis and the shoulder girdle, so they're the two areas that are normally affected. However, each limb girdle has its own particular muscle weakness, a certain pattern of weakness that develops, and certainly on MRI you can distinguish different limb girdles from the pattern of muscle, the different muscles that are affected. With dysferlinopathy, what tends to happen is people are diagnosed later, around sort of late teens into very early 20s, so they may have a very normal childhood, a very active sporty childhood has been found in a lot of research studies, and then they'll gradually find that they can't maybe run or they can't go up onto the tiptoes, and that's quite often the first symptom that somebody will have. And it's because the calf muscles, the gastrocnemius muscle, is one of the first muscles to actually be affected. So coming up onto tiptoes is almost a clinical indicator that dysferlinopathy may be worth pursuing. But gradually over time, it's the pelvic muscles and the shoulder girdle muscles that are affected. So people with dysferlinopathy will eventually lose ambulation, so they'll not be able to continue to walk, and then if they have a very severe form of disease, that can go on to affect upper limb movement. So raising their arm above the head, for example, would be really difficult. It's quite uncommon for people to have a lot of distal involvement in their hands, so in terms of maintaining very good dexterity, that's mainly preserved, although there are a couple of little muscles in the fingers which do get affected, and that can affect the flexion of the fingers. So people can experience symptoms such as, for example, if they wanted to wash their face, that can be quite difficult. So there are certain, between the different limb girdles, there are different patterns of muscle weakness which give them particular symptoms. So that's sort of really the dysferlinopathy would be sort of going up onto the calves, pelvis, shoulder girdle, and then a few will have sort of distal involvement. It's very rare that you have any cardiac or respiratory involvement with dysferlinopathy. So that's where it differs to something like Duchenne, for example, where those the respiratory and heart muscles are affected. But the research that we've done, it's not as common in dysferlinopathy to have problems with the respiratory and the heart function. So we're really looking at motor symptoms. Again, speech isn't affected, swallow isn't affected, so it's purely sort of musculoskeletal muscles that tend to be mainly affected. I work clinically, so I see people who have dysferlinopathy, and obviously we chat in clinic as well as doing our assessments. And what I found was a lot of people lose the ability to move from a sitting to a standing position before they actually lose the ability to walk. And this is quite an anomaly because quite often people that lose muscle strength around their hips, they'll struggle to walk and to go upstairs, things like that. But people with dysferlinopathy, again, because of the pattern of muscle weakness, they keep some of their hip muscles and they keep some of that strength, so they're actually able to continue to walk in a fashion. It's effortful for them, but they can do it. But what they really struggle with is going from a seated position into standing. And clinically, so many people tell me that that's a real problem for them. So, for example, if they go to a restaurant, they can't get out of a normal chair. If they go to a GP surgery, a hospital waiting room, the theatre, there are so many places in society where we have these types of chairs which are really difficult for someone with dysferlinopathy to stand up from. However, there was no evidence to support this, and the feeling I was getting from chatting to people was that this actually prevented them from going out. It's just such a difficult thing for them to do that they don't go out for dinner, they don't do normal social activities that we do. And for some people it affects work as well. If they can't, if they're having to get on and off chairs throughout their working day, it's just too effortful for them and too much, just too fatiguing. What we would like to do, well, what I would like to do as a clinician, obviously there's no treatment for dysferlinopathy, so the way that we help people is through equipment or maintaining muscle function, just trying to make people's lives easier. And the only way that you can do that is obviously make people aware of the problem and the things that could be done about it. So I decided to look into if there was a link between somebody's ability to go from sitting to standing with social participation and employment. And I looked at some baseline data that we had collected as part of, there's a clinical outcome study in dysferlinopathy that's been running for over 12 years. And it's a natural history study into people with dysferlinopathy, and there are 205 participants altogether, over 16 sites internationally. So we gathered all this data, and I used some of the baseline assessments from this, and I looked particularly at how a clinician rates if somebody's able to go from sitting to standing, and then I looked at the participants, sort of their perceived ability to do tasks which included sit to stand. And then I looked at another measure, a quality of life measure, which looked at their social participation. So by comparing this, I was able to look at the performance, but also the lived experience of these people. And I used a statistical test called a chi-square test for association, which tells me if there's a link between these three variables. And I found that there was a link between the clinician-rated ability to sit to stand, what patients report, and their quality of life. So there is a link between these three things. I also carried out a small focus group with some patients with dysferlinopathy who had difficulty with sit to stand, and just got their ideas of how this impacts them on a day-to-day basis, what they do to get over it, because essentially it would be good to know how this can be managed moving forwards. And the results from the focus group very much sort of match the quantitative results, that there is a link definitely that people stop going out when they can't get up from a chair. What came out, which was interesting for me as a clinician, is there were some anomalies when I looked at the results. There were some people who were unable to sit to stand but actually said that they were going out. And I was thinking, well, what's facilitating that? How is that happening? And when I broke it down and looked into what equipment these people had, I found that the majority of them actually all had wheelchairs. So having a wheelchair eliminates the need for somebody to get up and down from chairs. The difficulty that people with dysferlinopathy have is because they retain the ability to walk, they don't meet wheelchair criteria. So there's a big gap here where people would benefit from having equipment, but because they're still on their feet and walking, they don't meet criteria for it. So I'm hoping that the work that I've done can really be used to inform wheelchair services, equipment providers, clinicians, that we need to sort of get the word out there that people need to have access to equipment a lot earlier on. So as soon as somebody stops being able to get up from a seated position, we should be thinking then about getting equipment in for them. We shouldn't be waiting until they actually lose ambulation, because that could take another couple of years, and that's 2 years of social life that's been taken away from them. So that really is the crux of the work that I did. I wanted to sort of prove that there was this relationship so that we can inform equipment providers. And also I'm hoping it will help to inform standards of care, because there are no standards of care formally for patients with dysferlinopathy at the minute. So if we can say people need this equipment, and that can go on the standards of care, it makes our job much easier in terms of approaching equipment providers and wheelchair providers. So this is a huge area that some people don't want a wheelchair earlier on. They don't want equipment early on. They don't want to look different. And this is a huge area, and we need to find the balance really, because it's really about trying to give somebody the best quality of life for as long as we possibly can. That's what I see as my role. And sometimes, having a chair, which means that you can then go out and have dinner, and it's not going to be a huge stressful experience because you can just go and stay in a chair, you don't have to get on and off awkward seating, is, for some people it's worth doing that. Having a wheelchair or a frame or equipment doesn't mean you have to use it all the time. It's almost having something in your toolbox that you can pull out when you need it. And I think we need to try and change the way that people think about aids and adaptations and equipment, and not look at it as a defeat. As you say, it's about, I've got this to help me when I need it. It's like a pair of glasses. You'd put a pair of glasses on if you needed to improve your vision for a particular period of time. We need to start just changing the way that we look at equipment and not see it as being, something for, that admits defeat or that sends a message out that you've got a disability. It's all about enhancing people's lives. And there will always be people that don't want to go down that road, and that's completely that's completely up to them. But it's having the option, and people don't have the option at the minute because they're put into a category of, can you walk, can you not walk? And that's what gives you the equipment. And that's what we need to change, those perceptions of when somebody is deemed requiring that equipment, because certain pieces of equipment used as they are useful to somebody can actually prolong somebody's social experience or social participation or the ability to work. And then, life is much better if you can still do these types of things. So I can see that argument that not everybody wants equipment, and I think it's working with the individual patient, what's right for them, and trying to, as I say, get that message across that it's to be used when you need it, as you need it, and it's just something that you've got in your back pocket almost to pick up and use. But unless people have the options, we need that as a starting point. We need people to be able to go and get the equipment if they feel that they need it.